everyone, and thank you for joining us this evening. So I'm just going to load a little CV slide. I'll make this a little bigger. Okay, so as I said, good evening, everyone. My name is Ronan. I'm joining you this evening from Dublin, and my background, as you can see here, I graduated just over 10 years ago now, back in 2011 in University College Dublin. I did a rotating internship in Davies veterinary specialist in Hertfordshire in the UK. And then I spent about 1.5 years in first opinion practice with an orthopedic bias in Northern Ireland. I returned to UCD in 2014 for a 4-year residency in small animal surgery, ECVS residency, combined with a doctorate. And I completed that in April 2018. And then I became a diplomat of the European College in 2019 in February. And I have remained on as faculty as associate professor and head of small animal surgery since. So that's my background. Okay, Mel, are you happy if I continue on with the remainder of the presentation? Is that okay?
Yes, thank you, Ronan.
Perfect, thank you. Okay, so over the course of the next 45, I hope to try to do this within 45 minutes, 50 minutes. These are the sort of learning outcomes. So at the end of this lecture, you should have an understanding of what are axial pattern flaps that we use in dogs and cats. How do we use them? What are the advantages of them in comparison, for example, to subdermal plexus flaps, which would be another type of flap that we can use, or a cohort of flap. Skin grafting, things like that. Are there disadvantages of the use of these flaps? The different types of axial pattern flaps. So this evening, I'll take you through what I consider my sort of top 5. There are about 12 and upwards of that, of these recognized. But obviously, we don't have time to go through every single one of them. But I'll take you through, as I said, my sort of top 5. The next part is quite practical, which looks at how I create these flaps, why do I create them, the planning that goes into them and the design. I think that's very important. So this is very much a sort of a practical based, as well as we'll also touch on some of the literature, looking at complications and outcomes of the use of these flaps. And then at the very end, hopefully we'll have time for these, just some clinical cases of my own where I have used these, what I would consider successfully. In terms of recommended reading, obviously there is Michael Pavletic's Skin and Reconstruction book, which for sure is an excellent resource. I must admit, these are my top 2 go-tos. So Yola Kerpenstein and Gert Terhaar's Reconstruction book. Very practical, shows you very nice images, and is sort of step-by-step for each of these. All of the landmarks are in there. And we'll use this book a little bit tonight as well. And obviously Tobias and Johnston as well is obviously a fantastic resource. Okay, so if we take a look at what are axial pattern flaps. So first of all, we need to talk a little bit about the anatomy of the skin. And as you know, the skin has a segmental arterial blood supply. So it has a number of these simple and mixed cutaneous arteries that go between muscles and through muscles respectively. And axial pattern flaps include a direct cutaneous artery and vein. So this means that they can be of a larger size in comparison, for example, to subdermal plexus flaps. These direct cutaneous arteries, these will arborize and feed 3 plexi. So we have the deep subdermal or subcutaneous plexus, we have the middle or cutaneous plexus, and then the superficial plexus or subpapillary plexus, as it is called. As I said, the axial pattern flaps include a direct cutaneous artery, whereas for our subdermal plexus flaps, which typically involve making, think of a single pedicle advancement flap, you will typically have 1 pedicle remaining, and that pedicle and its subdermal plexus, the collaterals to that plexus, is what is keeping that subdermal plexus flap alive or viable. So as a result of these subdermal plexus flaps, the axial pattern flaps, including a direct cutaneous artery and vein, it allows for them to be much larger, as I said, in comparison to the subdermal plexus flaps, which are typically smaller. In terms of the forms they can take, most commonly we will use peninsular flaps, which means that they have an intact base, and we rotate at that base, which on some occasions, a downside to that, we can create a dog ear. The alternative is to use an island axial pattern flap, and that means where all 4 quadrants are incised, but we obviously have preservation of the vascular pedicle. The risk with that being that there's greater risk of twisting or kinking of that vessel and then necrosis of the flap, but it would be more cosmetic than a peninsular flap because of the whole issue with the dog ear. In the vast majority of axial pattern flaps that we create, we will use a bridging incision, and this is obviously to link the donor and the recipient site. But there are some descriptions of creating a tubed flap, so that is an alternative where we can use the flap to reach a distant site. We can rotate them up to about 180 degrees. Obviously, beyond that, you can have a situation of venous congestion and then necrosis of the flap, so that's not ideal. And then they can take different forms in terms of the actual structure. So for the most part, these are obviously cutaneous flaps, but they can include muscle. So for example, the superficial temporal axial pattern flap, we usually include the frontalis muscle deep to that. Mucocutaneous examples do exist as well. So the example would be the facial or the angularis oris, which obviously includes a mucosal part as well as a cutaneous part, and we can separate those as well. In terms of the advantages of these axial pattern flaps, again, because they include that direct cutaneous artery and vein, we can create large flaps and therefore close pretty large defects. We can also achieve early closure without extended open wound management. So what I mean by that is, take the example of skin grafts, full thickness meshed skin grafts. Ideally, we would be placing these down on top of healthy granulation tissue. Of course, there are reports of putting them directly down on, without granulation tissue out there with success. But for the most part, we do aim for, treating of wounds with granulation tissue and then full thickness mesh skin grafts. But you don't need perfect wound healing conditions for these larger axial pattern flaps. They can be quite robust, but of course, just like any wound, there really should be no contamination, gross contamination, infection, or necrotic tissue. So the same wound healing principles do apply, of course, but they can take more abuse, I guess, than free skin grafts. If there was concern for some contamination, you might be considering the use of a drain in these cases. For the most part, they have fairly excellent flap survival rates. DipECVS are a sort of range of 87% and upwards, and their survival rate is believed to be at least 50% higher than subdermal plexus flaps for the vascularity reasons we've just covered. They're fairly easy to develop and rotate. You can follow published guidelines. No specialized equipment is required, which is very useful. And as I said, they can be placed directly onto bone, tendons, ligaments. You don't need to have a granulation tissue bed for use of these. In terms of disadvantages, potentially they have some limited use with regard to distal limb skin defects. You might consider in some breeds that have long torsos and short legs like Dachshunds, they might be more lend themselves better, I guess, for use of some of these axial pattern flaps, such as the thoracodorsal, for example. You might be able to reach distal limbs in those type breeds. There is also, and we'll cover it later, descriptions of using skin stretchers. This is an example here, a published example from a case in the literature of where they use skin stretchers in order to be able to stretch the skin associated with the thoracodorsal, and they were able to achieve closure of a wound all the way down to the carpus. In terms of other disadvantages, cosmesis might be an issue. Obviously, of variations in hair coat length and direction of hair growth, the color of the hair. This is another example we can use here. You can see the differences in hair coat direction and length from this thoracodorsal flap. There is another mention out there in the literature of the use of a facial or the angularis oris, and when the hair or the skin flap was rotated, the way the hair was growing was irritating the nose, and the owner needed to constantly keep clipping that skin flap because of the dog was sneezing as a result of the hair tickling the nasal planum. There's variable ease in terms of identification of the arterial blood supply. So some of these flaps are very easy to identify, such as the caudal superficial epigastric. Others, such as the omocervical, they're more variable in terms of the location of the arterial supply and how easy it is to identify it. And the other important point I want to make is, particularly in areas where radiation therapy is available, obviously, to treat something, you take a mast cell tumor, for example, on a distal limb, to treat this with a more marginal excision, and to make use of, post-operative radiation therapy is obviously one option. The other option would be to go with a wider excision and something like this is a genicular axial pattern flap. But the only risk with this really is, that if this was an incomplete margin or a dirty margin, you just look at the size of the scar that you've now created. So this is an important consideration, particularly in areas where you have access to radiation therapy, and certainly needs to be discussed with the owner. So there are lots of different types of axial pattern flaps. In this image alone, there are 12 of them. Not all are labeled, but here obviously we have the superficial temporal, we have the facial or the angularis oris here, we have the caudal cervical, we have the omocervical here, we have thoracodorsal, we have the superficial brachial, here's the caudal superficial epigastric, we also have a cranial superficial epigastric, which we don't use as commonly. We have the deep circumflex iliac, dorsal branch and ventral branch, with that ventral branch potentially providing some blood supply to that flank fold. We also have the lateral caudal or the tail axial pattern flap, and then we have the genicular reverse saphenous conduit flap. So there are lots of these out there published. In terms of the practical tips that I think are important, rule number one is, make sure you have enough skin clipped and prepped. You need, obviously, these flaps are taking advantage of neighboring mobile or loose skin and recruiting that skin into an area where, you have less skin. So you need to make sure that you've clipped and prepped enough, but also that you've draped widely in theatre. You need to make sure you position the patient so you have access to donor and recipient sites. You might need a hanging limb technique. Obviously, if you have a limb lesion, tumor, or a resultant skin defect on the limb, make sure that you have plan A, plan B, and plan C. So that is very, very important. And obviously, we discuss with the owners that plan A is X, and we have plan B is to do Y, etc. So make sure that you have all of these in your head, prepared, and I would go as far as having them mapped out on the dog in terms of with a sterile pen and ruler, basically. I don't know if you're familiar with this, the KISS principle. This comes up a lot on various soft tissue listservs, and it basically stands for keep it simple. Some people say stupid, but I say keep it simple, silly. And this basically means that on so many occasions we would have these hopes for using a genicular flap or a thoracodorsal, but if the wound comes together by primary closure, then that is the way we go. So on many an occasion we're preparing and excited to use an axial pattern flap, and we end up achieving primary closure. So that is super important, that we apply the simplest method of closure for the animal in terms of morbidity. I always will obviously outline the gross tumor margins and my desired margin of excision, whether that be a narrow margin, a marginal, or a wide. And I will also draw the flap, and I'll draw the bridging incision, and all of that will be ready to go. It's obviously crucially important to say, make sure you can close the donor site, and I'll show you how I sort of do that. That's very important. You make sure that the flap is going to be long enough. I usually use a swab for that, and I'll show you what I mean by that. So I sort of rotate to see, do I have enough length, because you'll have some degree of skin sort of contracture as well, and with the rotation it'll be a little bit shorter than what you have maybe anticipated it would be. And I live by this saying, which is to measure twice and cut once. So I think that's very, very important. I usually outline the flap in terms of I incise the flap with a scalpel blade, usually a 10 blade. I don't incise it with cautery or electrosurgery. Make sure that you dissect the flap at the appropriate level. So for example, with superficial temporal, you're going deep to the frontalis muscle. For a thoracodorsal, you're going deep to the cutaneous trunci. And for the caudal superficial epigastric, you're going deep to the supramammarius muscle, right down to the external rectus sheath. So you need to make sure you know those levels, otherwise you could obviously injure the flap. I usually like to leave a generous amount of subcut with the flap, and that is again me trying to prevent any sort of being too clever and too close to the skin, and obviously impairing the blood supply to the flap. I will often use a sort of a push cut technique in terms of how I do my dissection. So a dissection usually starts at distal, working towards the base of the flap. And the image here is really just to show you this sort of a push cut. So with a Metzenbaum scissors, I will have the jaws open somewhat, and I will just sort of push the scissors through the sort of fascial planes and the subcutaneous tissue. And this might increase your chances of not injuring a vessel if you were to come upon one. Obviously, it's not foolproof, but it's safer than going in a sort of chop, chop, chop and discover you've actually cut the feeding vessel. So that's important. And then it's important that we don't, manipulate the flap again and again, is particularly at its edges, and causing, congestion or necrosis of the distal part of the flap. So I will usually use either skin hooks or towel clamps or even stay sutures to manipulate the flap into position. So this is just a random example of we'll have clinical cases at the end, but a dog with I believe a sarcoma on the lateral aspect of the stifle. So you can see a fairly wide prep in this area. In terms of options, obviously we'll have discussed primary closure with the owner. We're preparing here for the flank fold flap, which is not an axial pattern flap. It's for the most part a subdermal plexus flap. It might have some blood supply coming from that deep circumflex iliac, the ventral branch. But I've also prepared here for caudal superficial epigastric as well, just in case. So that's what I mean in terms of have your options available, and make sure you have clipped and prepped enough and that you've draped enough to take or make use of this available skin. So in this example here, we've outlined the gross margins of the tumor. We have, in this case, probably a low-grade soft tissue sarcoma with a centimeter margin around, and we have the flap outlined. The genicular would have been another option here, but this mass would be at wiping out those saphenous, the genicular branches of the saphenous artery. So that wouldn't be appropriate in this case. But that's just to show you sort of the planning that goes into these. In terms of the bridging incision, this is obviously important. This is an example of a genicular axial pattern flap used for that mast cell tumors, which we'll talk about later, a suspect high-grade mast cell tumor on the distal limb. So with that size defect, it would be very hard to close that primarily. So the genicular lended itself quite well for this case. And the bridging incision, in summary for me, it's at the base of the flap, and it's on the side toward which the flap will be rotated. So in this case, obviously it'll be rotated anti-clockwise or towards the left side, and that's where the bridging incision between the two will be. In this example here of a thoracodorsal axial pattern flap, it's being rotated in the same direction, in this sort of anti-clockwise direction, and so we create the bridging incision in that same way. I like to use towel clamps once I've performed the rotation, and I obviously want to make sure I can close that donor site as well. But I basically apply lots and lots of towel clamps, and then I'll start progressively closing this, usually in 1 to 2 subcut layers with monocryl 3.0 or something similar. Skin sutures as well. I usually go for either staples or Ethelon sutures. I usually reach for a drain, such as an active close suction drain, Jackson Pratt or a Blake drain. This allows me to quantify the volume of fluid being produced, particularly if you've any bleeding muscle bellies that might be, producing fluid. If you've dead space, I would reach for a drain. I don't always reach for a drain, but it is something at least to consider. Post-operatively then, or immediately after the surgery, I usually just apply Primapores. I might apply a compression bandage, modified Robert Jones, for 24 hours. And you don't want to have excessive compression causing, obviously, hypoxia to the flap and flap necrosis. Analgesia is important. I personally avoid use of ice packs or cold packs, just with the whole issue of vasoconstriction and potential tissue hypoxia, again, affecting the survival of the flap. And if I do use a drain, just in practical tips, I'm looking for that fluid production to plateau. We're usually looking for daily fluid production of less than 2 mils per kilo per day, less than. And obviously the character of the fluid should be good as well, clear sanguinous fluid or serosanguinous, i.e. some blood tinged. So this is just an example in that case we've looked at previously. I'm just going to flick through this quickly, but we've obviously outlined our tumor, and we're about to outline now the flap, which is, again, this is a subdermal plexus flap rather than an axial pattern. So you see, in terms of I pinch together, I have an idea of how wide I need the flap to be, but I'll use my my thumb and index finger to see what can I close safely, and I'll mark that with the skin sort of pinched up, and then I'll do that in several levels and just basically let the skin off and draw the outline of that flap. So that's how I do it, and I know that I'll be able to close that. So the other thing I want to show you is in terms of, I use this swab to kind of give me an idea from, so I'm anchoring it here at what's called the pivot point, and I go to how long of a flap do I need, and that will tell me, you know, in this case, I decided that I didn't actually need it to be this long, so it actually could be a little bit shorter. But anyway, that's the sort of two important points there in terms of make sure you can close the donor site, and make sure the flap is long enough, basically. So coming back to the KISS principle, in this case, you can see we're all ready for that flap, and in the end, we were able to achieve primary closure. And I would usually put the leg through a range of motion and just make sure that there's absolutely, you know, no important tension on that. And that happens on several occasions. This is another incompletely excised sarcoma on the lateral thigh. We applied a 2 centimeter margin. Obviously, we would have discussed with the owner options in terms of close monitoring, radiation therapy in the UK, scar excision, and the owner elected for scar excision. And in this case, again, we were looking at using the flank fold flap, and again, we achieved primary closure. So on many occasions, these flaps aren't needed, but obviously it's good to have them in terms of a backup. So we're just going to take our way through the literature and look at some of these flaps. So I've picked out a few of these, one being the superficial temporal, the facial or angularis oris. We'll take a look at the thoracodorsal here, caudal superficial epigastric, and the genicular. So these are sort of my top flaps that I would use. I can't say I use the caudal auricular very commonly, almost cervical, for the same reason. Sometimes for axillary wounds or neck wounds, I might use that almost cervical. The caudal auricular we've potentially used for facial defects that we rotate rostrally. So we'll take a look at these. So this is a very nice flap, in my opinion. I think it lends itself very nicely for any of these areas shaded in orange. So this is the outline of the flap that you can do. So usually what's described is 1 centimeter proximal to the patella and about 1.5 centimeters distal to the tibial tuberosity. And then we draw 2 parallel lines which will run parallel to the shaft of the femur and headed towards the base of the greater trochanter. If you go further than the greater trochanter, you have issues with distal flap necrosis. So this flap is quite useful for rotating down in this region here of the lateral cross. Can be used on the medial aspect of the cross as well, and the caudal aspect. And this flap is based on the genicular branches of the saphenous artery and medial saphenous vein. So there's a nice image here from an older paper with Pavletic, really nice. This here would be the patella. Here's the patellar ligament here, or patellar tendon, and the insertion onto the tibial tuberosity. And you can really nicely see these genicular branches, basically, of the saphenous artery and medial saphenous vein. As I say, I really like this Kerpenstein and Terhaar book. It just shows you in a very practical way of the landmarks for these flaps. I'd encourage it as a resource for you if you don't have a lot of experience. So this is just showing you, obviously this is just in a cadaver specimen, creating a skin defect on the lateral cross, the creation of or outline of the flap, creation of the flap, and then we create the bridging incision, which would be from this point here down towards the center of the defect, which is here, and then we rotate down the flap and make sure you can close the donor site. It's important, as I said, that you don't create this flap too long, because you end up with flap necrosis, because the genicular artery is not a very large vessel. So that's just an important point. In terms of the literature, you'd expect there to be more published on this, but there isn't really a lot. So these are the main 3 papers. One of these is an older sort of experimental study from Pavletic. So they had 8 dogs, and each dog acted as its own control. Basically, they created 2 groups. So on one side, the flap was raised and transferred to a skin defect over the lateral aspect of the distal limb. And on the other side, the exact same thing was done, but they actually tied off or ligated the what we know to be the perfusion to the flap, which is the genicular branches of the saphenous artery and medial saphenous vein. And of course, the non-ligated group had about a 90% flap survival rate, is something similar to what you see here on the left, and the ligated group had about a 55% survival rate. So this is just an area showing you here necrosis of the distal aspect of the flap, confirming that these are the vessels involved in this axial pattern flap. So this is just really showing you, obviously, that is the important vascular supply to this flap. But I think we can take something else from this study, and that is that, you know, there isn't 100% flap survival here. It was 90%. And it's important to say that the flap extended to the greater trochanter on both sides. So about a 90% from this experimental older study. I won't spend too much on this one. This is just a case report, you could say, with 2 dogs where fairly extensive lesions on the sort of lateral cross region. One was a dog with a fibrosarcoma with fairly extensive margins of a 3 by 4 centimeter fibrosarcoma, where they used this flap, and the other one was this more chronic extensive wound on the lateral aspect of the distal tibia, obviously managed as an open wound for a period of time until they achieved a nice granulation bed, and then successful use of the genicular flap as well. So in both cases, they had a small dehiscence, which was managed conservatively with second intention healing. So you can kind of see that there, and there's more of that sort of scar tissue formation from granulation tissue epithelialization. The more recent clinical study, again, shows very good success rates with this flap type. So this was from Terry Emerson in the UK, 22 dogs, and they had skin defects on the lateral and cranial cross. And the summary basically would be in 100% of dogs had 90 to 100% flap survival. So really, really good outcomes in this case. They did have some major complications requiring revision surgery in just over 10% of cases, and then a fairly high rate of minor complications. And that's the thing with these flaps. We can often have lots of these minor complications, which they're not that difficult to manage. So minor wound dehiscence not requiring surgery, post-op bleeding, prolonged drainage, seroma formation similar to what you can see here, and a surgical site infection. So that's the sort of largest clinical and most up-to-date study on genicular axial pattern flap. As we move on then to another favorite of mine, which is the thoracodorsal axial pattern flap. This, as you know, is based on the cutaneous branch of the thoracodorsal artery and vein. This vasculature basically is located or arises at the level of the acromion, just caudal to the scapula. And then this vasculature travels dorsally, sort of paralleling up the caudal aspect of the scapula. I'll say at this point, obviously, the mirror image of this on the cranial side would be the omocervical. So again, from Kerpenstein and Tahara's book, you can see the areas that this flap can reach. It's useful for skin defects on the neck, over the thorax, can be used for axillary region, and also over the lateral aspect of the elbow. And that's the most common reason I would use it in oncologic cases. In terms of the outline of the flap, just very quickly, the cranial margin is the spine of the scapula extending from the acromion. In terms of how to get to the, what is the caudal boundary of the flap, well, you basically measure the distance from the cranial line to the caudal aspect of the scapula. And then you measure that again, that same equidistant or that same distance again further caudally. So with the vessel in between both cranial and caudal lines. In terms of the dorsal line, it's usually the dorsal midline, but there are reports of extending it a little bit further to the contralateral scapulohumeral joint. So this flap, you need to make sure that you dissect deep to the cutaneous trunci muscle, and this is the case with a lot of these flaps, that you're going deep to a sort of superficial cutaneous muscle. So again, very quickly, just a crude drawing here in that textbook. Obviously, in this example, you could arguably say that you could just close this primarily, but just for demonstration purposes, the outline of the flap is created. We create the bridging incision, which would be extending from this point here. And this really just is, the reason I put this in is just to highlight that this would be the cutaneous trunci muscle here. So it's important that this is included with the flap and that you dissect deep to that. And then flap is rotated into position. In this example, they've used a Penrose drain and closure of donor and recipient sites. Largely speaking, I would say that this is a robust flap. If I draw your attention to, there are experimental studies in cats and in dogs. These are a little bit older studies, and they have very high survival rates in terms of surface area of flaps, almost 100%. But in some of these, the flap isn't actually elevated. They just, the flap isn't moved into a new position. It's just elevated and reseated. So potentially that's why higher rates of survival in comparison to actually moving them to another area. One of the sort of clinical studies does, however, report a partial tip necrosis rate of almost 70%. So only 3 out of 10 dogs in that study had complete flap survival, which we'll look at in a moment, which is a little bit disappointing. So this is the sort of literature, the pertinent literature, in my opinion, that's out there. We'll take a look at some of these. One of these is an older study, again, by Pavletic, experimental study, but the flap wasn't moved into a new position, so what's called orthotopic. So basically the flap is elevated and just replaced in its original position. So clearly this is just for experimental research. But very high survival rate of 98%. This is an example, a case report published by David Holt and Runge, and basically they had a dog with a very extensive wound. They managed it to the point of a very nice granulation tissue bed extending from elbow to carpus, and they used skin stretchers, basically applied caudal and cranial to the proposed thoracodorsal axial pattern flap, and then they had elastic cables connecting these sort of Velcro pads, which the owner tightened daily. And this was basically taking advantage of what's known as mechanical stretching of the skin or biological creep. And then the flap was based on this right side, as you can see in this image here, but they extended all the way across midline to the contralateral, I think, scapulohumeral joint, and they had 100% flap survival. So that's a nice report of, this extends all the way down to the carpus in this case report. There is, just not to confuse things too much, but there is another thing that could have been done here, which is known as the delay phenomenon, or what's called ischemic preconditioning of a flap. So what can be done is where the outline of the flap would be actually incised, but this flap not elevated. and then you just suture it back into position. And then in about 3 weeks, you come back and elevate the flap and put it into position. And the idea is that you train the flap to survive with the one pedicle that's remaining, basically. So that's known as the delay phenomenon, or ischemic preconditioning. Of course, it does require 2 anesthesias, so it isn't without that bit of extra morbidity. So this was that APR study, 10 dogs, most commonly used for after tumor resection, complete flap survival in 30% of the dogs. They did have about a mean of 1/5 of the flap to necrose in up to 70% of the dogs, or 70% of the flaps. And then they had some of these common flap-related complications like seroma, bruising, edema, necrosis. So these are common across a lot of studies with axial pattern flaps. In terms of cats, there is again an older experimental study where they basically created 8 thoracodorsal flaps, and these were created in the island form rather than the peninsular form. 4 of these were described as orthotopic, meaning that they just basically outlined the flap or incised the outline of the flap, elevated the flap, and just put it back in position again, whereas 4 were heterotopic, which is where they actually rotate the flaps into a recipient site, and that was basically headed towards antebrachial lesion or defects created down as low as the carpus. The success rate in this study was quite good. So overall, all flaps were successful, but 7 out of the 8 of them had minimal necrosis of about 2%. So quite good results in that study. So that's genicular and thoracodorsal. As we move on to the caudal superficial epigastric, for the most part, this is considered a fairly robust flap. In terms of the anatomy of this flap, as you know, the caudal superficial epigastric comes from the external pudendal, which comes out of the inguinal canal. In terms of landmarks, for drawing this, again, from that Kerpenstein book, the sort of medial margin is ventral midline. The lateral margin here is you measure from ventral midline to the nipples and go equidistant again. In terms of the cranial margin, usually we go as far as including the 3rd teat number 3 or mammary gland number 3. You can go to include number 2, but obviously the longer you have the flap, the greater the risk of distal flap necrosis. And obviously the flap is based in this caudal region here, and it's important in male dogs where you'll have prepuce here that you include the base of the prepuce, otherwise you're at risk of affecting the vascularity to the flap. And in this, just like others we've looked at already, you need to make sure that the deep plane of dissection is all the way down to that aponeurosis of the external abdominal oblique, so deep to the supramammarius muscle. In terms of, this is quite a versatile flap in that all of the areas in orange is where you can extend this flap. We've certainly had cases here in the hospital of mast cell tumors in this sort of perineal region, extending down along the medial aspect of the stifle, medial thigh. So this is, there's quite a versatility to the use of this flap. Again, we've kind of covered this quickly, but this is just showing you in a cadaver specimen with a created lesion in the region of the stifle, and using the ipsilateral caudal superficial epigastric, create our bridging incision, and then we rotate about 180 degrees and close donor and recipient sites. There's another example of that from, this is mentioned in Tobias and Johnston, again for a lesion in the medial aspect of the sort of proximal cross on the medial aspect, down along that sort of medial thigh. This is another case here at UCD from a few years ago of recurrence of a mast cell tumor along the previous scar line, and excised with 2 centimeter margins and use of the ipsilateral caudal superficial epigastric axial pattern flap. So for sure, this is one of the most consistent flaps in terms of the anatomic landmarks. It's fairly easy to obviously identify these landmarks and usually to see this vessel. Experimentally, flap survival has been shown to be very good in a study, again, from Pavletic. There is an older study that shows about a 90% flap survival rate, but there's a more recent study from Kate Foster in the UK that had some more, how would I put it, the success rate wasn't as good as what has been reported in some of these other studies. So this is that APPER study. They had 10 dogs, 10 flaps, 90% of which had complete flap survival. They did experience some postoperative complications. Again, these are nothing new: bruising, edema, seroma, incisional dehiscence, things like that. I've included some of the images from this paper, just showing you again the sort of versatility of this flap. So this dog with a large sort of caudal flank and lateral thigh wound, which obviously would have been managed as an open wound for a period of time, and then use of the ipsilateral caudal superficial epigastric. And this would be the more typical sort of use of that flap down along the medial aspect of the thigh and onto the sort of cross region. This is that more recent study from Foster. So a large number of dogs, 51 dogs, 19 cats. Overall, you can see that quite a high rate of complications in this study. Up to 2/3 of them in dogs develop complications. Again, the vast majority of these were minor. In cats, about half developed complications. Again, the vast majority of them were minor. So overall, a good outcome in both dogs and in cats in about 80% of cases. And I just included again some of the images from that paper. So this was to reconstruct a defect on the lateral thigh, and you can see the distal necrosis of the flap, which obviously would require debriding of that management as an open wound for a period of time. And in terms of options, I guess just expanding that conversation would be either elevating the flap and advancing it, or managing this in some other way. There's another example of use of the caudal superficial epigastric for, you can see again the versatility of this getting to a wound at the sort of perineal region. And again, in this case, well, it appeared fine initially, developed this distal flap necrosis. You can see this sort of dark discoloration and black sort of headed towards eschar formation, which required debridement and again management in some other way. There is a nice report out there from Philip Mayhew and David Holt, where they actually used simultaneously both of these flaps in a dog with a very extensive wound in the left caudal flank and sort of lateral thigh region. So this sort of schematic shows you nicely how they employed both of these, one going around the sort of caudal aspect of the thigh and the other one used in a more conventional way. And they had 90% wound coverage achieved and 100% flap survival. So a very nice use of both of these, and the donor site closed primarily. This was a study that looked at the use of this flap in cats. We've already talked a little bit about this study for the thoracodorsal, but this was used for the caudal superficial epigastric. So a similar sort of design, 8 cats, and they created these caudal superficial epigastric flaps. 4 of them were just raised and resutured in position, and another 4 were heterotopic or rotated basically to extend down to the metatarsal region. And all of very good results in this study. All of the flaps survived without necrosis. In this case, there was some mild seroma and partial dehiscence in 2 animals each. The next flap I wanted to talk to you about was the superficial temporal. So most commonly we use this flap for lesions in this area here. So this again is from Kerpenstein's book. So lesions in between the orbits, in between the eyes, or sort of dorsomedial to the eyes. I think this is a really nice flap to consider. So this obviously is based on the cutaneous branch of the superficial temporal. In terms of the landmarks for this, so if we take this example here where the flap is based on the right side, so it's based on the zygomatic arch. In terms of the landmarks, caudally we're limited by the ear. So the ear is the caudal aspect of the zygomatic arch, is the caudal aspect of the caudal incision. and the cranial incision is limited by the eye. So it is just sort of caudal to the eye, or at the level of the lateral orbital ligament is what's described. In terms of how far across you can go, the recommendation, according to published literature, is to go to the middle of the dorsal orbital rim on the contralateral side. So it should not really cross this point here, that dorsal orbital rim. This is a very nice angiographic study from, I think it is from Dr. Maria Fahy from the US, and she shows very nicely in this experimental study from a good few years ago now. This is the external carotid artery here. This branch here is the caudal auricular, and then we have here the next branch to come off is the cutaneous branch of the superficial temporal here. So this is the sort of location of that vessel. It's a little bit towards the caudal aspect of the flap. So in this example here, this is a cadaveric specimen. So again, just a lesion created, and then this the creation of the elevation of the flap. Flap is rotated into position, and then we close the donor site, as you can see in the images. In terms of the literature, there's reasonable amount published on this. Just going to take a look at some of these just in the interest of time. So this was that study I mentioned. This is another sort of experimental study. There's a study in dogs and another one in cats. And basically, they looked at a few things in this study. So Group A basically is following the recommended guidelines that we know. So based on the zygomatic arch, going back to sort of the ear and limited cranially by the eye, and going to the middle of that sort of dorsal orbital rim of the contralateral eye. The control group, basically similar to that previous study I showed you with the genicular, is where they created the exact same flap, but they actually ligated the cutaneous branch of the superficial temporal. And then Group B is where they extended further than what is recommended all the way across to the contralateral zygomatic arch. So we can take from this that if you follow the recommended guidelines, you'll have a sort of survival in the region of 90%. Whereas if you extend the flap too long, you sort of achieve something in the region of 70%. So you will have distal flap necrosis. And obviously, if you ligate the vessels, which we wouldn't recommend, you will have something similar. And this might be reflecting of the fact that when we've sort of removed that direct cutaneous artery, perhaps that flap is surviving as a sort of subdermal plexus flap. And that's why we hadn't 100% failure of that flap. This is a more recent study, clinical study by Benito Della Puerta in the UK. So they had 9 dogs and 10 cats. Overall, 90% of the animals had 100% flap survival. So some very good results in this. And again, reasonable rate of postoperative complications, 42%. A major rate of complications of 5% and minor of 21%. So again, just some images from that study. This would be the sort of typical use of this flap. This was a case after an enucleation, looks like in a cat. And another example of a case after a tumor excision in that sort of nasomaxillary region. But in this case, they were quite creative with the use of this flap. So the flap in this case is based on the contralateral on the right side, and they have sort of taken advantage of elevating this flap in this region here. So this wouldn't be the sort of conventional use of this flap. Again, this is based on the other side, and they're basically elevating the flap in this region here and rotating this rostrally into that defect. But unfortunately, this case developed some distal flap necrosis, and again required debridement and some other means of closure, either by second intention healing or re-elevation of the flap. That's just another example from the paper for another neoplasm. That would be the conventional sort of use of that skin flap. I thought this is a nice example in the literature. So this is a case of a dog that experienced a very severe nasomaxillary tissue loss from an unknown trauma. And in this case, the authors created a tubed flap taking advantage of the superficial temporal axial pattern flap. So this tube flap was created. So this surgery was performed in 3 steps. The first part involved the creation of that tube. The second part of the surgery, this was again coming back to this sort of delay phenomenon or ischemic preconditioning. So they basically cut at the, so this would be on the right side of the animal. The definitive flap was based on the left side. So after a number of weeks, they came back and sort of severed half of the sort of tube on the on this side, which is the right side of the pet, and then just resutured it. And the idea is that they're trying to force the flap to survive. You're sort of as you limit its blood supply, you're training the flap to survive. So they come along and sever half of the pedicle on the right side, and then after another week or so, they come back and sever the remaining half, or basically they sever the entire amount at that point. And then the tube is elevated and transposed into position in order to cover the recipient site. That's then left in position again for another number of weeks, and then you remove the tube, the excess skin that's not required. So they had a nice cosmetic outcome in this case, but this was a 3-part surgery taking advantage of a tubed bipedicle initially superficial temporal axial pattern flap, but with the overall goal of making a long single pedicle axial pattern flap using that left temporal superficial temporal flap. And then finally, the facial or angularis oris flap. So I think this is a very nice flap again for the sort of maxillary lesions here, or lesions in the mandible. So this flap is described in the literature as the facial or the angularis oris. In terms of the different ways you can use this flap, so you can use this in terms of for its actual skin to rotate into these areas here highlighted in orange. And when we create this flap, it's important to know that the base of the flap is really the commissure of the lip. So the dorsal outline of the flap here runs along the ventral margin of the zygomatic arch. The ventral margin of the flap is basically contiguous with the ventral boundary of the mandible. Okay, and in terms of the caudal aspect of the flap, what's recommended is the sort of vertical ear canal, but in some reports, authors will go as far as the wing of the atlas, which is C1. Obviously, the longer you make it, the greater the risk of distal flap necrosis. It's important when we elevate this flap, and we would do it again from in this case towards the base of the flap, so from caudal to cranial, we elevate it deep to the platysma muscle. So that is important again, that we don't injure the vascular supply to this flap. So these are just this is just an angiographic study, just again showing you this would be the facial here, and this here is the angularis oris. And another example here from a case. This here, not the best diagram, but this is the facial artery here, and again just showing you the angularis oris arterial supply. So this here would be what you would encounter if you were trying to make use of the sort of mucosal aspect of this flap rather than the use of the skin to close a cutaneous defect. So in these cases, we basically make a skin incision from the commissure extending caudally, and that's what you see here. And then with transillumination, or basically a sterile light coming from the mouth, you can identify these flaps and make your incisions in order to create a mucosal axial pattern flap, which is based on the angularis oris. So just a nice sort of ex vivo demonstration of the use of this flap. This would be a typical sort of lesion we might be closing in the sort of maxillary region. And this is the outline of the flap, just ventral to the zygomatic arch, back to the ear canal or LC1. And then the ventral boundary of the flap is sort of contiguous with that ventral border of the mandible. We need to make sure we elevate the flap deep, as we said, to the platysma, and you will have some vasculature here. There's that deep facial vein that you need to make sure you don't injure that, just from a point of view of bleeding. And then rotate the flap into position and close the donor site. So it's a really nice flap that you can use for either reflecting dorsally or reflecting ventrally for ventral chin sort of lesions. There are quite a few papers describing the use of this flap. So in terms of the clinical ones first, this study included 4 clinical cases, and usually for oncologic reasons again, so very similar to what I showed you in that ex vivo, so creation of this of the skin flap. This is obviously following tumor excision, and then rotation of the flap dorsally into position. You can end up with a little bit of a dog ear as a result of this, but that usually goes away with time. And in this study, they had fairly minor complications. All of the flaps remained viable, and as I said, things like minor flap necrosis, dehiscence, second intention healing in one case, and then some self-limiting billowing of the flap during expiration, and that's really as a result of the extent of the tumor resection, because there's opening into the nasal cavity. But this is self-resolving and usually goes away by about 7 days. This is another paper from Dr. Bryden Stanley in the US, again about 8 dogs, usually for these sort of nasomaxillary, orbital or intermandibular. I just wanted to put this in because it just really nicely shows you the versatility of this flap for either going dorsally or going ventrally. So some nice examples in that study. And overall, all of the flaps heal, so a reasonably robust flap. Some typical complications, again, flap edema, dehiscence, treated by second intention or healing or minor revision surgery. Josh Milgram from Israel has a nice study looking at, again, the anatomy associated with the use of this flap, and he describes a clinical case after a squamous cell carcinoma of the upper eyelid after a recurrence, I believe, and so nice flap survival in that case, but full flap survival. There are lots of reports in the literature of use of angularis oris for and the facial for closure of palatal defects, hard palate defects. This is one from Sarah Boston. So multilobular osteochondroma, where they created the mucosal angularis oris axial pattern flap, rotated it here, as you can see, up into the palate. And this is 2 weeks after surgery with complete flap survival. This is another one, again, just use of this angularis oris buccal flap for reconstruction of palatal defects. So they're in this case report, they're just showing how they dealt with complications associated with this flap. So this is the flap being used, but developed dehiscence and oronasal fistula, but they effectively just amputated the base of the flap and sort of flipped it 180 degrees into this once it had a strong attachment at the caudal aspect of that oronasal fistula. And this is the sort of end result that you end up with here. And then they created a random pattern muco periosteal sort of flap to augment that first flap and achieve successful healing in both cases. Another example of use of it for recurrent oronasal fistula, and again, this image just really nicely shows you, there isn't skin involved with this flap. This is just buccal mucosa, but with the angularis oris, and that's basically brought into the mouth and sutured into position. A lot of people will remove teeth, such as the molar teeth at the sort of the last molar on that ipsilateral side, because as the animal is chewing, there's risk of injury to the flap. So a lot of authors will remove those molar teeth because of that. So just to finish with, I'm not sure how we're doing with time. It's just 8:30. I was just going to run through some clinical cases quickly. Is that okay with you, Mel? Are we okay for time?
Yeah, feel free to just go through a few. That'll be fine.
Perfect. So these are just some of the cases that we've had here in the hospital. So very quickly, this was an 11-year-old Springer Spaniel with a cutaneous mast cell tumor measuring about 3.5 by 3 on the sort of lateral aspect of the elbow. This dog also had a metastatic prescapular lymph node. I guess I will say in all of these cases, we discussed with the owner in the various sort of surgical doses in terms of, obviously we talk about radical, which would be amputation, wide margins, more narrow margins or marginal excision, and obviously then the final one would be intralesional, which is not really done, which is, you know, scooping out tumor basically. So we have this conversation with all of our owners. I usually sort of summarize it as, when we're talking about wide versus narrow margins, obviously with wide margins, the further away we're staying from the tumor, the higher the chance of achieving a complete histologic margin, and therefore the higher the chance of, the lower the risk of recurrence as a result of that tumor. However, while there is that lower risk of recurrence, there is a higher risk of reconstruction-related complications. And then the opposite is true the closer you come to the tumor. So for a marginal excision or a narrow margin excision, obviously there is a closer risk, or a higher risk, I should say, of incomplete margins and tumor recurrence, but usually a lower risk of reconstruction-related complications. So we have that conversation with all owners. In this case, the owner decided to go for a sort of a narrow excision. We would have discussed options in terms of trying to achieve primary closure or the use of a skin flap. But in this case, just to walk you through it, this was treated with a 5 millimeter lateral margins and aiming for a centimeter deep margin. Sorry, aiming for a deep margin, basically, of a fascial plane, if possible to get. I guess another important point to say that we CT these, we do a contrast CT of these cases. And if we have concerns with regard to the deep margin, we will have a conversation with owners in terms of, you know, if we can't guarantee the deep margin, there isn't really much of a point in going crazy with lateral margins. So it's this whole issue or concept of why go, you know, crazy wide in terms of lateral margins if you can't achieve a deep margin. So that's likely to have influenced why we didn't go with crazy wide margins in this case, because of the, I guess, lack of guarantee based on the CT scan of getting that deep margin. You can see in this case, we've outlined the thoracodorsal flap. The bridging incision will be in this region here. And then this is following outline and creation of the skin flap just prior to rotation. And then, as I said at the beginning, I like to use towel clamps just to get everything opposed, and then I start progressively closing. So you can see this sort of a dog ear that you end up with here. Now that does go down with time. I'll show you an image of that. But obviously an alternative would be to risk doing this as an island, where you actually cut all 4 borders and just rotate it on the vascular pedicle. So this was just once the animal had gone home. This would probably be after about 3-4 days post-operatively. You can see, obviously, the donor site is healing fine. We certainly have some bruising of the actual flap itself, and certainly we would keep a very close eye on that. And certainly there would be a risk this would progress, you know, to necrosis or dehiscence. But thankfully that started to improve in the days that followed. So this is 7 days post-operatively. Everything is looking intact, no evidence of any dehiscence or drainage. Obviously there is some flap edema here, maybe a little bit of seroma. And this was at about 3 weeks post-operatively. So you can see already that the dog ear is reducing, and with time that diminishes completely. And we had 100% flap survival in that case. The next case we've already sort of touched on already. This was a dog with a suspected high-grade mast cell tumor based on an incisional biopsy on the sort of distal cranial cross of a border collie. And again, the same sort of conversation would have happened with the owner. In this case, it appeared as if the you know, based on the scan that was performed and actually just palpating the mass, it didn't appear to be, you know, fixed to the underlying tissues. So following conversation with the owner and taking everything into account, we went for a wide margin of 2 centimeters. Obviously, there are other options available for sure. One being to take a more marginal approach and follow it, you know, radiation therapy if required. So in this case, just to walk through the actual development of the flap. So again, as we said, sort of 1 centimeter proximal to the patella, 1.5 centimeters distal to the sort of insertion of the patellar ligament at the tibial tuberosity, and then following all the way up to the base of the trochanter, the greater trochanter. We make our bridging incision, and I like to use either stay sutures or towel clamps to rotate that flap into position, basically. So once we have the flap rotated, I usually try to, you know, apply towel clamps and make sure we can close the donor site, and then just start a progressive closure in 2 to 3 layers. So this was the immediate post-op. I was fairly happy with the result. Again, we've commented on this at the beginning in terms of you end up with a very sizable scar here with the use of this flap. This was 3 days post-operatively. The rest of the flap was looking good, but I was a little bit worried about this distal area, just in terms of the skin wasn't really knitting together nicely. And just looking at the appearance, so at 5 days, we're starting to see a sort of a demarcation that we're having distal flap necrosis. And at 7 days post-operatively, we had dehiscence. And you can sort of see this line of demarcation here, which is sort of boundary between viable and non-viable. So in this case, we revised this and resected the necrotic distal tip of the flap, undid all of these skin sutures in a sort of stepwise fashion, only as required in order to be able to advance the flap distally again. This next case, so this was a dog, an 8-year-old crossbreed with a grade 1 sarcoma, very large grade 1 soft tissue sarcoma over the left thigh, about 10 centimeters in diameter, subcutaneous. And in this case, we had a 1 centimeter lateral margin, and the deep margin consisting of fascia lata on the lateral thigh. And in this case, we used the caudal superficial epigastric. In terms of other options, obviously this wouldn't have been possible to close by primary closure. The flank fold was really, for the most part, wiped out with this. There might have been some degree of flank fold in there. Obviously, you can rotate in the medial aspect of that flank fold to come across. But I think we would have been tight for skin, so we went for caudal superficial epigastric. So just followed the standard published guidelines all the way down to the aponeurosis of external abdominal oblique, rotated into position. And then this is what we ended up with post-operatively. So this is immediate post-operative and the use of a Jackson Pratt drain as well. So in this case, again, we had a little bit of bruising of the flap, some seroma formation, which you can see, but some more bruising there. You can see in this image, we had some distal flap dehiscence, which was managed basically with revision closure. And certainly we would have taken a swab of that for culture. And we ended up with pretty much full closure of the flap and uncomplicated donor site healing as well. So you can see skin sutures here where we revised that area of dehiscence. Maybe one more. So this was Frenchie with the typical sort of, I think this was a mast cell tumor. So this was suspect high-grade mast cell tumor. So this lesion just dorsal medial to the patient's right eye, and sort of very conventional use of this flap. But you can see if you were to try to close this primarily, you probably would have a lot of pulling on that eye or exposure, keratitis or ectropy and things like that. So this flap can be quite nice to achieve closure without any degree of tension on that wound. I'll just say quickly, Bryden Stanley in the US has another paper where there was involvement of the medial canthus, and a very clever thing is that if you do have involvement of that medial canthus, an important thing to do is to pass a suture like a 2/0 or similar proline or ethylon suture going down through the nasolacrimal duct and exiting the nose, because you want to make sure you don't get closure of that duct associated with healing or scar tissue formation. So leaving that suture in place for about 7 to 10 days can really help healing to occur around the tube rather than healing actually closing the tube. That was another case we had in the hospital here from a few years ago. And again, a similar use of that flap. So again, coming in closer to that medial canthus, and we use the suture in that case as well. So that's pretty much it. A bit of a roller coaster of cases in the literature. Thank you very much for your attention. I welcome any questions you might have. So,
Ronan, we have 2 in the question and answer session. Can you see those?
Yep. So one, hi Cesar. I have a question about medial elbow wound in a small, oh sorry, they disappeared. Medial elbow wound in a small dog, 5 by 2 centimeter defect, planning use of superficial brachial. Any tips for this one? So on the medial elbow, so I must admit, obviously you're probably aware, Cesar, there is a recent paper looking at superficial brachial. I must admit I'm not the biggest fan of that flap, and I think that paper supports it. So in those cases, I would probably, obviously it's hard when we can't have one-to-one conversation here, but I would probably be looking at the, you have a few options. So one would be the axillary fold flap. Perhaps your defect is eating into that flap. So maybe that's the reason you're not going for that one, but I would certainly be looking at that flap as an option. The other option, of course, would be to use the lateral thoracic. Whether or not you could rotate down that thoracodorsal, that might be another option. I guess the short answer for that one is I'm not the biggest fan of that superficial brachial, just in terms of complications with it. And there is a very recent paper, I think, by the same group of Benito and Stephen Baines. I think there's a fairly high complication rate associated with that flap. In terms of restriction of activity, so we certainly rest these patients. I guess in terms of what that means, we would basically, owner would basically provide definitely housebound rest. So the patient would be housebound, likely room bound. Obviously, they can be provided with short lead walks. I just take it nice and easy basically for the first 2 to 3 weeks post-operatively. If you're worried about things like seroma, obviously excessive exercise can be an issue as well. So I guess in short, what a typical discharge instruction would say would be, taking it nice and easy, restricted exercise for the first 2 to 3 weeks, short lead or harness walks for those first 2 to 3 weeks. And definitely they would be housebound. So I probably wouldn't have them as confined as a crate rest, similar to after a fracture repair, but they would be fairly restricted, and minimizing of any excessive activity, jumping up and down on furniture, running up and down stairs, any sort of boisterous playing. I would eliminate all of that. Do you have any information on how many of these cases require antibiotic prescription post-op? So that's a good question, obviously. I think that really comes down to a case-by-case basis. So it depends on what type of wound you're excising. So if it's dealing with obviously therapeutic use of antibiotics, if you do have a positive culture and you're treating an infected wound, obviously we try to not use these flaps until you have a wound that is, largely speaking, free of infection, free of contamination, free of necrotic tissue. But if you did have a positive culture, let's say you took a swab at surgery just immediately prior to closure, and you had a positive culture, I would obviously use culture guided antibiotics. With regard to empirical use of antibiotics, I think if you're in the situation of having a clean wound in terms of types of wound classification, and you have a short surgery, obviously I would be looking at not using antibiotics in these cases. But if you did have, you know, the reasons that I would consider to use antibiotics would be if you had prolonged surgery or wounds in the area of potential contamination. So take that for a sort of perineal wound or something like that. I would consider use of antibiotics, but for the most part, if the surgery went to plan, we were dealing with a clean wound in terms of wound classification, and the surgery was quick, I would be just going for perioperative antibiotics, and that might extend into the, you know, the next morning, but not a continued course of antibiotics. Given the large clip area and presumably long prep time, did you use a bear hugger to maintain body temperature, and how does reduced temperature relate to risk of post-op infection? So that's a good question as well. Absolutely. I have the luxury of working in a university where we have boarded anaesthetists, so there will have been all sorts of mechanisms used to try to maintain core body temperature. Certainly in some of those larger clips, that is an issue for sure. It is for certain a theoretical risk in terms of hypothermia and wound healing. But in those cases where that degree of a clip is required, for sure it's a theoretical consideration. I must admit it's not something I would discuss with an owner, you know, that the effect of hypothermia on survival of our flaps. But it is a reasonable theoretical point for sure. Did you find any specific risks from breed factors, concurrent disease? Would you consider a diabetic too high a risk of breakdown? Another very, very good question. Again, it is something that I would just take practically with that owner, you know. So any animal, I guess, that is immunosuppressed, immunocompromised for whatever reason, whether it be hypothyroid, diabetes, certainly we would be aiming for the simplest method of closure because of that. I might be considered, you know, to leave my sutures in place for longer in those cases. We think of cats, for example, with this sort of slower rate of healing they have compared with dogs. So I might be a little bit slower to remove sutures in cats compared to dogs, particularly for larger flaps. But I guess to directly answer your question, it's all on a case-by-case basis. I can't even recall many diabetics I've had to do these types of flaps on, but certainly it would be a consideration we would discuss with the owner. That would be an important consideration. How long is the typical GA time? So I think the reality is, with time and experience, I remember as part of my residency, we did these sort of on occasion, obviously always aiming for the simplest method of closure. I think when you see more and more of these oncologic cases, you end up doing more of these sort of complex flaps. And so with time, I think you can become very quick. So for example, that sort of thoracodorsal flap, probably in terms of surgical time, would have been maybe something in the region of, you know, 60 to 90 minutes. Superficial temporal, something similar. That caudal superficial epigastric might have taken a little bit more time, but I think the reality is with time, practice and experience using these flaps, you become very, very comfortable with outlining, you know, the landmarks for these. You're not second guessing yourself. Everything is sort of intuitive for you, and I think that's where a lot of the time is wasted. Whereas when you have more and more practice and experience, you very, very swiftly, you know, just complete these components of the task. To answer your question, how long is GA time? I think it really depends on the case. Again, working in a university hospital, clip and prep time probably around 40 minutes, 45 minutes, or anaesthetist, like any opportunity to use, you know, nerve blocks. So that would take maybe 20 minutes, 30 minutes as well. Then you have the surgical time on top of it, and then the recovery time. So I hope that sort of indirectly answers your question. Let's see, we just progress down some of the questions. So plan B, axillary fold, plan C, maybe thoracodorsal. So I think that's reasonable. Feel free to email me, Cesar, if you want, and I'll take a look at it and give you an opinion. But as I said, I would be looking at thoracodorsal, axillary fold, maybe lateral thoracic as my sort of options in that area. In the third case study, I think the the one before the Frenchie, it developed a seroma despite the drain. So that's a good question. Was this because the drain didn't work properly or didn't reach that far down the leg? So I think that was the caudal superficial epigastric. I must admit, I'm probably one that keeps drains in for longer than is required. Obviously, we know that, you know, if you use a drain, the drain in itself is going to stimulate some fluid production. So the drain production will never, well, typically I'll say, won't go to zero. It'll probably plateau at something under 2 mil per kilo per day. So I usually aim for something that is consistently under 2 mil per kilo per day. And in those cases, when you do remove the drain, on some occasions you can have some form of seroma form. I would expect it wouldn't be anything near what would have formed if, you know, you just closed it and didn't put a drain. So that's part A. In terms of part B, was it not far enough down the leg? As you know, with a closed suction drain, it doesn't work by gravity. So as long as that whole sort of area is connected by a sort of a vacuum, it should work. There might be a component of, I suppose, as soon as the drain was removed, there was obviously some residual sort of fluid being produced, and that accumulated in the dependent part of the wound. So I hope that answers your question. Question about thermal injury from heating pad, including a whole back of dog as second-degree burn. Yeah, so that's obviously another sort of complexity in that you have a burn injury there. I think the cases that we've had in the hospital of those, I think lots of things are possible. We've had cases where we felt it was possible to completely excise the burn and to achieve primary closure. We have had cases where that wasn't possible. We ended up having to obviously debride necrotic tissue, manage the wound for a prolonged period of time as an open wound, getting a granulation tissue bed. And then we have had cases of where, you know, for example, we've used the actual flank folds as full thickness meshed skin grafts. In terms of axial pattern flaps, let me see. I guess one thing, just even before we talk about axial pattern flaps, it might even be possible to use subdermal plexus flaps just in terms of advancement flaps from dorsal. So coming from cranial and coming from caudal, that might be one option. It might be possible to use, again, the flank folds with incorporation of the ventral branch of deep circumflex iliac and rotating up into a dorsal position. Again, depending on the extent of the lesion, just thinking of the various options we have available. So thoracodorsal is probably not very much use to you. The tail is probably too far caudal. Coming up the sides could be caudal superficial epigastric, but whether it would achieve that sort of true dorsal aspect. I think in terms of the cases we've had, we've used the flank folds, whether as, you know, subdermal plexus flaps or incorporating the ventral branch of the deep circumflex iliac, making it an axial pattern flap. Using subdermal plexus single pedicle advancement flaps from cranial and caudal in the form of a H-plasty. Or the other option would be to take the likes of the flank folds or auxiliary folds and making them into full thickness meshed skin grafts. I think that would be another option. But again, if you want to email me separately, I'll happily give you an opinion on that. Are we okay for time, Miller? I can keep going through these. I don't mind going through these, or whatever you want.
I think if we could round up in the next 3 minutes or so, I've got just a few things to say at the end. So if you could just run to 9 o'clock, that would be amazing. Thank you.
Yeah, that's no problem. Are there instances that closed suction drains would be recommended for extensive lesions to prevent seromas? So I would say to at least consider the use of the drain. You know, if you pick up a text like Tobias, they will say that, you know, these closed suction drains should be considered for all axial pattern flaps, unless you're dealing with an area such as, you know, maybe in the region of the face, or where size is an issue, perhaps, in terms of actually getting that drain to, in terms of the space it would occupy. And sometimes we have to cut axial, we have to cut Jackson Pratt drains or Blake drains to make them fit. You can as well fashion sort of active suction drains, even using a butterfly catheter and the phlebotomy tubes that are used in a large animal. So basically, you can, if you think of it, so if you think of the butterfly catheter, use the non-needle part, and create some fenestrations, and that can be tunneled into the under the flap, basically, through a separate incision, and then the needle part is going into the vacutainers, and you can change the vacutainers that can act as a closed suction drain. So for the most part, I would say to at least consider the use of them in most of these cases, particularly if you have a lot of dead space, or as part of your deep plane, you are taking muscle and you'll have some bleeding muscle, anywhere where you think there will be a lot of movement maybe, and seroma formation, which you might be limited in areas such as the face, or where there's just space, the confines of actually physically fitting the drain. After the blood supply to the donor area is transposed, is there localized necrosis? So after the blood supply to the donor area is transposed, so that's not really an issue. In this, take the thoracodorsal, for example. So once you elevate that flap and respect the landmarks, or the published guidelines for that, we're just really closing the donor site. And I can't say I've had issues with donor site unless you're in a situation of where you had a lot of tension, perhaps, or infection, and you end up with necrosis and dehiscence. So that might be something. But I think adhering to published guidelines, you shouldn't really have that issue too often. Is multi-perforation and axial pattern flap recommended for more stretching? So I don't do that, is the short answer. I wouldn't do that. I would be worried that you would injure the blood supply to the flap. And I should say, even another point would be, and it sort of marries in well with this point, would be, the use of tacking sutures, even with these flaps. I would be cautious again that you're not going to damage the blood supply. So I personally would be cautious with the use of tacking sutures. And that's why I will reach for a drain quite a lot, because I'm not tacking the flap down in several areas underneath the flap, if that makes sense. I'm just really doing it around the edges of the flap, but I'm using a drain to prevent seroma and prevent that sort of floating of the actual flap itself.